Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Liz Muggah, to introduce the session. Liz?
Good morning. Thanks, Tara. Welcome, everybody. We've got a great panel today for you. And as you know, this session that we host is Main Pro accredited. So you'll get information about that in the emails that you were sent. We'll introduce ourselves in just a moment, but I will start with the land acknowledgement. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from unceded Algonquin and Anishinaabe territory. I'll hand it back to you, Tara, now.
So we are obviously always doing a land acknowledgement to introduce these sessions, and I'm sure you are in your work as well. The key part of that, of course, is situating where we are and whose land it is and has been for many years. And a friend recently introduced me to this interesting website where, no matter where you go in Canada, you can type in the postal code to understand whose land it is. And so it helps us to, it also has some good tips on doing land acknowledgements. So check it out if you haven't already. Next slide. We're delighted to continue to bring these sessions to you, and a reminder that all of the sessions are recorded, and you can access the recording for this session as well afterwards at the website. These sessions all build on each other. So if we refer to past sessions, please do check those out. We've had many past sessions, as you know, on Omicron and other aspects of COVID. Next slide. I'm delighted to introduce our panelists today. I'm going to turn it over actually to them one at one to introduce themselves. Next slide. Ruchi?
Good morning. My name is Richie Murthy. I'm an infectious diseases physician in Ottawa, Ontario, working at the Queensway Carleton Hospital. Today, I'm receiving an honorarium for this talk. Thank you.
Ashley?
Everyone, it's great to be here today. My name's Ashley Verduyn. I'm a family doctor by background, and I'm the chief at Providence Healthcare, which is a rehab hospital located in Scarborough, Ontario. I also received an honorary today.
Liz?
Thanks. So I'm Liz Mugga, and as I said, I'm the president of the Ontario College of Family Physicians. I'm also a family doctor in Ottawa and the assistant dean wellness for the Faculty of Medicine here.
Next slide. And so I've introduced myself, but I've listed here some places where I've received grant support, salary support, or an honoraria, only 2 from for-profit companies that don't pose a conflict for today. Next slide. So we know that, we're in the midst of a very tumultuous time still. We are, I think many of us are breathing a sigh of relief that case counts are coming down and hospitalizations are coming down. At the same time, I know that there's actually a lot of anxiety out there about the fact that we're reopening, and many of the health measures that we'd had in place are now no longer going to be there. And what will that mean for the future? How should we be advising our patients in this tumultuous time? And then, of course, and layered on all of that is the chaos in our streets. That's a reality in particular for those of you who live in Ottawa. So we're delighted to always bring this community together to be here to answer your questions and support you. Next slide. We've drafted today's session based on the questions that you've submitted at the registration. We're going to start with Ashley talking to us about post-COVID condition. We're then going to go to Richie, who's going to give us an update on where we're at with Omicron and some of the latest evidence related to vaccines. We're then going to hear from Liz about how we can support our own wellness during this really difficult time. And I know so many of us have been feeling burned out coming through December, January, and now Feb. Through it all, we're going to, of course, be doing Q&A live. So in addition to using your questions to draft this session and the flow and the agenda, we'll take your questions live. Next slide. As usual, just a reminder to put your questions in the Q&A box, and please use the thumbs up to upvote them. So we'll be answering the questions live that receive the most thumbs up. So better to give a thumbs up to a question that's similar to yours rather than to retype it in. But do please use the chat to share your thoughts, any resources you might have, connect with others. We'll be posting links in the chat and information in the chat as well as we go along so that you have it. Next slide. So without further ado, I'm just going to turn it over to our first panelist, Ashley, to give us a little bit of a talk around post-COVID condition. Ashley.
Thanks, Tara. So hi, everyone. It's really great to be here, and thanks for tuning in to learn a little bit more about this very disabling disorder. Today, I'm going to try to provide you a brief sort of summary of post-COVID condition and really focusing on practical tips for family physicians. So next slide. So what is post-COVID condition? Well, for the greater part of the last 18 months, there's actually been significant uncertainty and a lack of consensus about a definition for post-COVID condition. But back in the fall in October of 2021, the World Health Organization developed a definition. And so I'm going to read it out to you because I think it's important to unpack this a little bit. So post-COVID condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months that cannot be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others which generally have an impact on everyday functioning. Symptoms may be new onset following initial recovery from an acute infection, or persist from the initial illness, and symptoms may also fluctuate or relapse over time. So it's a quite long-winded definition, but what I want to point your attention to is that it's a history of probable or confirmed SARS-CoV-2 infection, because throughout the pandemic, there's been times where patients have not been able to access testing to confirm their diagnosis, and that's certainly the case now for many. And just to also point your attention to the fact that symptoms can wane and come and go and can be new or different throughout the course of this illness. So next slide. So the prevalence of post-COVID condition. So estimates actually vary quite widely in the literature, and this is based on factors such as the case definition, sampling strategy, and also many observational studies have been limited by bias. But what we think is that 1 in 3 infected with SARS-CoV-2 experience at least one persistent symptom, 1 in 4 experience symptoms that last at least 1 month, and 1 in 10 experience symptoms lasting beyond 12 weeks. So as of January 6th, there was a cumulative total of 877,000 cases of SARS-CoV-2 infections in Ontario, which basically means conservatively that 87,000 to 292,000 Ontarians had or might be currently affected by post-COVID condition. And I know there's some interest in risk factors, but risk factors for post-COVID condition are also less appreciated in the literature, but there are some signals showing that perhaps older age, being a woman, having a higher BMI, and actually having more acute symptoms of COVID and perhaps severe COVID-19 infection may be risk factors. But the truth is we see post-COVID condition in a wide spectrum of people with COVID-19, even those with very, very mild symptoms. Next slide. So what are the symptoms of post-COVID condition? The truth is there are many, but these are the most common. So one of the most common long-term symptoms we see is fatigue and post-exertional malaise. Post-exertional malaise is a worsening of symptoms following minimal cognitive, physical, emotional, or social activity, and it's quite common in patients with post-COVID condition. The symptoms typically worsen 12 to 48 hours after activity. We see shortness of breath, cardiac symptoms like chest discomfort, and I'm sure everyone's heard about brain fog and cognitive dysfunction. This also seems to be a fairly common long-term symptom. And we see a lot of mood symptoms, PTSD, anxiety, depression, sleep disturbances, and dysautonomia. And I wanted to mention POTS today. And this is something we see fairly commonly in patients presenting to our clinic. It stands for postural orthostatic tachycardia syndrome, and it's a form of dysautonomia that's associated with the presence of excessive tachycardia with standing and symptoms like dizziness. So the diagnostic criteria for POTS is a rise in heart rate of 30 beats per minute or more during the first 10 minutes of standing in the absence of a drop in blood pressure. And patients will typically describe feelings of their heart racing or not being able to do anything, go up their stairs because their heart is beating so quickly, and feeling symptoms of dizziness and chest pain. SARS-CoV-2 virus enters the body via the ACE2 receptor, and the ACE2 receptor is actually expressed in numerous cell types throughout your body, more than 10 different organ systems. And so there's more than 200 symptoms associated with post-COVID condition, likely because of this. Next slide. So I wanted to emphasize the impact of this disorder on patients. So whether hospitalized or not, persistent symptoms of post-COVID condition affect a person's functional abilities and quality of life. And so certainly these symptoms can cause patients trouble doing their basic activities of daily living, like dressing, for example, and some of their instrumental ADLs, like going grocery shopping or managing finances and transportation. And we see a reduced ability to care for dependents and family members as well. So parenting can be a challenge. Those that are looking after seniors in their homes, it might have caregiving challenges. And we've certainly seen difficulties in returning to work and or school. And you may have had patients struggling with this in your practices too. And I wanted to again emphasize the negative psychological, social, and financial impacts that this disorder is having on patients. And there's been quite a bit of stigma attached to this as it's a new disorder. We've been trying to figure out what it is, why it happens. And patients report feeling, I would say, under-supported by the medical community, their friends, and even their family members. And some have not been able to go back to work or have had to quit their job. And there's also some significant financial impacts. Next slide. So how can we help our patients with post-COVID condition? This is a really handy infographic that Ontario Health has created. Thank you, it's in the chat box as well. And I heard there's a little summary of this guidance document coming out shortly. But basically what you can do is when your patients come to your practice, make sure you take a thorough history, obviously, and ask them about when they had the symptoms, did they have a test, what was positive, when was it positive? And then it's about a basic physical examination, obviously. And I just wanted to emphasize checking vitals, checking for orthostasis and some of that autonomic dysfunction. And if your patient has described some of those symptoms of their heart racing, checking their orthostatic vitals and looking for POTS is important. But I want to emphasize that this is actually a clinical diagnosis. It's really based on symptoms. There's no specific test for post-COVID condition. So really what you're looking at is taking their history and putting it together. And if you're thinking that this is what it probably is. You can really go down a rabbit hole of over-investigating patients because they do have can have a myriad of symptoms. So just be careful about, it's good to rule out things that are serious, but also make sure you use testing and referrals judiciously. In terms of management, there's no specific approved medication for post-COVID condition at this time. There's certainly multiple studies looking at this right now. Medications are focused more on managing symptoms or associated conditions. So for example, if your patient has a post-viral cough, you would manage that the same way as you would for other viruses. And certainly we sometimes still recommend, like for example, budesonide or intranasal steroids, and obviously treating associated mood disorders, PTSD with CBT. And then for POTS, there are some specific treatments like compression stockings and making sure your patients drink enough fluids. And then we do sometimes use medications like beta blockers or Verduyn for this condition, as it can be cause a lot of symptoms. And then I'm going to talk about supported self-management next, but this is a way that family physicians can probably help their patients the most who are suffering from this condition. And the other way you can help your patients is by following up with them regularly. And although we don't know a lot yet about the prognosis of this condition, certainly 1 in 10 experience symptoms beyond 12 weeks, which means that 9 in 10 actually will get better by 12 weeks. And then when symptoms are really not improving or you're struggling with how to help your patients further, and especially if they're having disabling symptoms that are really affecting their functional abilities or their ability to work or parent, you can consider referral to an interprofessional rehab team. Next slide. So just briefly today, but I wanted to really spend a few moments talking about self-management. So this is one of the ways family physicians can really help their patients. So first, I want to mention that energy conservation and pacing is an important thing to understand with post-COVID condition patients, because remember I mentioned that post-exertional malaise is quite common in these patients, which means that doing too much activity, and it doesn't mean just physical activity, it can mean, like I said, social or cognitive activity, can cause a worsening in symptoms. So what you need to tell your patients with the symptom or who are experiencing fatigue is that they need to think about pacing. And pacing is when you do less activity than you have energy for, and you're keeping activity short and resting often. So we use a gas tank analogy. It's a very simple analogy. Basically, it's that when you're healthy and well, you start your day with a full tank of gas, but when you have post-COVID condition, you may be starting your day with a quarter of a tank of gas or a half a tank of gas. And so you probably won't have enough energy to do all of the things that you used to do. So the 4 Ps we talk about as well, which is planning your day, prioritizing activities that are important to your patient, and doing those activities first. And those activities might be as simple as getting dressed in the day, or making their kids lunch, or potentially getting groceries, and then resting often and spreading those activities out through the day. We talk about position, which is important as well, and that's that you don't want your patients lying in bed all day. They need to shift positions, go for a little walk. But the idea of this is that you don't want to encourage your patients to do too much exertion. So you want to keep it below their energy threshold. And the way they'll learn about what that threshold is by doing some symptom journaling, and that's keeping track of their symptoms and what they're doing during the day, and then monitoring the symptoms for the 48 hours following that day. So that's to sort of determine what their energy levels are and what activities they're doing that precipitate that post-exertional malaise, and then they'll understand what they can and can't do. And then it's basically kind of slowly increasing activities over time. And then we don't even really talk about exercise until patients are managing those activities of daily living and managing those IADLs again. And then it's about slowly introducing kind of activity as tolerated. There are some really great online resources, which I'm going to share next, for managing symptoms, breathing exercises, box breathing, things to manage brain fog, headache, fatigue, and like I said, that post-exertional malaise. So next slide. So I wanted to share with you some practical resources that will help you and also help your patients. So these are some really great websites. The BC Health Authority actually has a great website where they have fact sheets in multiple different languages. So they have it in simplified Chinese, Tagalog, and Punjabi, I believe. University Health Network also has some great resources for patients and families. And there's some videos on there as well that patients can watch. The Ottawa Hospital, and thanks to Ruchi, she sent this to me this week. It has really come out with a lovely interactive tool for patients as well. And they have some information about symptom journaling on there too. And the World Health Organization has an excellent guidance document to support rehab and self-management at home. So not everyone has access to allied health in their communities, but this is a great guide for patients to kind of do their own program at home. And I mentioned the COVID Long Haulers Canada Facebook group. This was started by a patient with post-COVID condition, and it's grown quite widely, and your patients can find peer support in this group. And you might just want to preface that by saying that sometimes patients feel supported listening to other stories, but sometimes it can make them feel more defeated. And so I would just preface that they'll have opportunity to hear a wide range of stories about people getting better, but also people who are potentially not getting better. And next slide. So this is just a summary of the ways that I think family physicians can really help their patients. And I know you all do this already, but just validating and listening to your patients in itself is therapeutic. And when you see your patients, assess them for all the symptoms, and particularly focusing on what impact it's having on their quality of life and functional abilities. And then always consider, obviously, the needs of marginalized populations, because the COVID pandemic has unfortunately affected marginalized populations significantly, and they may have some who have a lower health literacy may have trouble navigating the system and getting the supports that they need. And supporting self-management, family physicians, I think, are well positioned to do this. And particularly focusing on energy conservation and pacing for those with fatigue and post-exertional malaise will really help your patients. And then advocating for your patients. I know we all do this already, but one of the big challenges we've been having in our program here is advocating with workplaces to recognize this as a disorder, and advocating with insurance companies and WSIB. And then I mentioned considering referral to multidisciplinary rehab programs when symptoms are not improving or are really severely affecting functional abilities. And so next slide. And in terms of programs for post-COVID condition, these are a list of, it's not a full comprehensive list, but this is a list of outpatient programs in the province that you can access for your patients who are really suffering. You may also be able to access allied health services through the LIN. WSIB also has some programs that are up and running. So just get to know what's available in your community if you think you need additional support from PT or OT or sometimes speech and language pathology. And that's it. So happy to answer questions later in the meeting.
Actually, I'm going to ask some of them to you now, Ashley, because there's a lot of questions in the Q&A about post-COVID conditions. So we might not be, we'll do some of them live, and then we might ask you to type the answer to some of them. So one of the ones, more popular questions was, one of my patients, Elizabeth McEwen asks, one of my patients requests low-dose steroids for long COVID. How do you suggest I respond, please?
Yeah, this is a challenge because there's no evidence-based treatment for post-COVID condition. So I mean, there's risks with steroids too. So I think you need to discuss certainly the risks and benefits and the fact that we don't know that this will be therapeutic for your patient. I don't know that I would recommend that, to be honest. But I mean, the truth is we're still learning about why patients are experiencing these symptoms. And I think there's a couple of different hypotheses, I would say, and autoimmune and inflammatory are some of them, but certainly, you know, probably if depending on what the indication is, I would say if it's sort of chronic shortness of breath or cough, inhaled steroids is probably safer. But yeah, there's no evidence to support that, I would say, at this time.
So Rosemary Lal, as well as another physician, I think later on, also asked a similar question. Rosemary Lal asks, is post-COVID recognized by WSIB and other insurance providers at this point? And would this diagnosis be viewed for ODSP and CRA tax credits?
It should be. It should be. There is an ICD code now for post-COVID condition. And yes, so WSIB is starting to recognize it. But we've certainly, like I mentioned, had to really advocate for our patients and write letters to insurance companies. Because the truth is these patients really need support. And like I said, that post-exertional malaise can come from too much cognitive stimulation. So in order to get patients back to work, you really need a graded return to work. And so they're going to need time off. And it should be recognized, but I'm interested to hear what your experiences are as well, because we've certainly had to advocate for our patients to access disability coverage and support, unfortunately.
Yeah, and so then there's some questions. Andrea Stern asks, can post-COVID affect those with asymptomatic infection, including children? And Patricia Lee asks, are all these long COVID symptoms regardless of vaccine status? So I guess, can you get it if you have had your vaccines and your booster? Can you get it if your COVID is asymptomatic, or can you get it if you're a kid?
Yes, yeah, sorry, I should have mentioned that this talk is mostly focused on adults, but yes, we have seen reports of this in kids as well. I believe it's not as common as we're seeing in adults. But yeah, you can get post-COVID condition with very mild symptoms, but the best way to prevent post-COVID condition is getting vaccinated. That being said, and the other reason I would say get vaccinated is that there is a signal that the more symptoms you have of post-COVID condition, the more symptoms you have related to COVID might be a risk factor for post-COVID condition. So getting vaccinated, even if you have less symptoms of COVID, if you get COVID, even though you're vaccinated, potentially puts you at less risk of getting post-COVID condition, if that makes sense. And yes, we do see patients who have some prolonged symptoms who've had very mild illness, so it is possible.
Aaron Bears asks, I've heard anecdotally that getting the vaccine sometimes contributes to resolution of post-COVID symptoms. Is there any evidence about this?
Yeah, that's an interesting one because one of the hypotheses for the cause of post-COVID condition is residual viral particles, but we don't really know. But there have been case reports of this, and I think it's another reason to encourage vaccination for sure.
Great. And so Leah sorry if I'm pronouncing your last name wrong, Mortellaro says, I have patients who want to be put on disability due to long COVID. What is the family doctor's role in this regard? Maybe you could speak a bit to that advocacy role you mentioned, Ashley.
Yeah, I think patients do need a lot of advocacy from their family physicians for disability, and I think it's your patient, and that's what I meant by also really discussing with your patients the impact that these symptoms are having on their functional abilities. And like I said, I do think patients with post-COVID condition do need a break often from work to like I said, slowly increase their activity over time, and then need support with returning to work gradually. So yes, I do think family physicians should advocate for the patients, particularly if they're suffering severe debilitating symptoms and can't work, because that's really what disability is for.
Okay. Are the immunocompromised more at risk of long COVID?
That's a good question. That didn't come out as a risk factor, to be honest. And they're also looking at to see if some of the treatments that are given to immunocompromised patients as part of the COVID treatment may be protective, but there's just so much about this disorder that we don't know. So there's still a lot of research going on, but no, I haven't heard being immunocompromised as being a risk factor.
Okay. And then David Dane asked, there has for decades been a literature around medically unexplained symptoms who have very similar presentations to long COVID, and treatment similarly focuses on rehab and self-management. What is the evidence that this is a unique clinical syndrome caused by COVID as opposed to generic medically unexplained symptoms? Regardless, the syndrome is quintessentially a family medicine challenge requiring skills to assist the patient.
Yes, well, there's still so much we don't know, right? So you're right, this does have a lot of similarities to chronic fatigue syndrome, but we also don't really know why that condition exists either. And I think there's some hope that research into post-COVID will also provide some answers to other types of conditions like this and open up treatment options. So, but I do think some of these techniques around self-management can help family physicians managing other patients with chronic illness.
So Darren Larson asks, I had a patient who went to a complementary medicine physician with 12 months of long COVID with symptoms like fatigue, vertigo, headache, visual blurring in one eye. Seeing every specialist, he gave her 25 milligrams of Cortef once a day for 2 months, and in 2 weeks, her symptoms completely resolved. So 3 months later, all is still well. Is there any evidence for that?
Not that I'm aware of, Certainly no randomized controlled trial about it. Mm-hmm. Okay. But there's lots of sort of anecdotal stories like this. So it's a hard place to be right now as we sort out when there is no sort of evidence-based treatment. Tara, can I just mention one thing though? I should have mentioned that there is a randomized controlled trial happening at UHN right now. It's called the RECLAIM trial. And so if your patients are interested in participating in research, Dr. Angela Chung at UHN is studying 3 different types of treatment to address the actual potential hypotheses regarding the cause of post-COVID conditions. So one of them is, I think, an anti-inflammatory, and another is an endothelial modulator. I forget the third one, but it might be a good option for some patients who are looking to try something as part of a research trial for treatment of this disorder.
Yeah, and so there have been some great comments in the chat just about our role around support and also advocacy. Even if we can't find the exact etiology, we have a great role for advocacy. I think there are folks who would appreciate just a little bit more clarity around some of the places where you can refer people if needed. So these are a great list of outpatient rehab programs. Is there anywhere else we should be considering, Ashley? And then, I think there were some questions about, are we actually able to even refer to these programs, or are these programs need a specialist referral, for example?
Oh no, these are definitely open to family physicians, and certainly our program here at Providence is very closely linked to primary care, and we really appreciate the involvement of family physicians. You're all sort of integral in the care of your patients. So all of these you can refer to. These are sort of centers, and we're all participating in data collection for post-COVID condition, but there are probably many other programs in your community. And it doesn't necessarily have to be a post-COVID condition program. You can also refer to probably the LIN, for example, if your patient needs physical therapy at home, and access allied health through your local health integration network. They're also private clinics. These are all publicly funded. But, like I said, WSIB is starting to, yes, thank you. Janine just posted. You can look at the Rehab Care Ontario website, and they'll point you in some other directions as well. But WSIB is also creating programs as well for their patients. So there's more and more coming, but there's still long wait lists at some of these. So I think our wait list now is quite long too. And we try to prioritize patients who have very severe impacts on their functional abilities because of that.
Thanks, Ashley. So next slide. So speaking of specialists, just want to flag here, Liz, I wonder if you wanted to speak to the eConsult service.
Yeah, so I think as many of you know, eConsult does have a robust service around COVID itself, but actually they have some really terrific resources, including subspecialty resources for post-COVID. And so some of them are listed there: infectious disease, respirology, chronic fatigue syndrome. So a really great resource to support you, and then some information about how to sign up there. I think we'll put that in the, there we go, it's just been put into the chat if you aren't signed up right now for eConsult. So that's another really good resource.
Thanks. So there are, I think, a few more questions in the chat for you, in the Q&A for you, Ashley. So please go into the Q&A and maybe you could type some of those. And I'm going to turn it over now to Richie, who's going to give us a bit of an Omicron update. And then I know people have some questions about variants, which Richie will speak about. And then we will, following Richie's talk about the Novavax and the booster question, which has come up a few times as well.
Thank you, Tara. And so today I wanted to offer you a bit of an update in terms of what's been happening in COVID for the last 2 weeks. Dr. Chagla did a review on the 4th, and I thought he did a really great job at addressing some of the epidemiology questions. And there was a great review of therapeutics during that talk as well. And so I deferred those slides if you're interested in looking into those details further. My goal today was to sort of give you snapshots of what's happened from February 4th till midnight, February 17th. I don't know what's happened this morning yet, but check Twitter. Something must have happened. We'll find out later. And so next slide, please. So one of the most notable updates that's happened in the last 2 weeks is the updated NACI guidelines on vaccination for those that have had prior infection with COVID. And they've divided it into several categories. To summarize briefly, if the patient has previously never had any vaccinations against COVID, it's advised that they receive the vaccine 8 weeks after their symptom onset. And in certain circumstances, if they're moderately immunocompromised or somewhat immunocompromised, that could be expedited to 4 to 8 weeks. And other than those that developed MIS-C, the inflammatory syndrome, that's quite severe, that population is still recommended to wait 90 days. If someone does get COVID after completing their primary series, so 2 shots or 3 shots in some immunocompromised individuals, the recommendations from NACI are to delay that next dose until 3 months after their symptoms have developed. Next slide, please. I wanted to just raise the caveats that come up underneath this chart that got published in NACI, which basically says that these are just guidelines, use clinical discretion when offering these vaccines. And I'd argue that's especially important in the unvaccinated individuals. For example, my own personal experience with this, having been on call for 2 weeks in the hospital, if there's an unvaccinated individual who's a reasonably distant from their initial infection and now they're willing to get vaccinated, I will take that opportunity to offer them that vaccine, even if it's at that 4.5 week mark and they haven't quite gotten to that 8 week mark, just to ensure that we've had the opportunity to act or strike when the iron's hot, if you will, and offer them further protection. And so, yes, there are a lot of caveats and discretions to this. So by all means, take a look at the NACI chart for further details, which are, of course, our national guidelines. There are some discrepancies with Ontario, which we may address through booster questions later. Next slide, please. So some other emerging information that's been published in the last couple of weeks. This correspondence was sent to the New England Journal from Qatar on February the 9th, which addressed what protection from reinfection looked like 6-7 months out from initial infection in unvaccinated individuals in Qatar. And what I thought was quite interesting was looking at infection protection levels across the alpha, beta, and gamma variants. It still ranged quite high, even against symptomatic illness altogether. And so I thought that was impressive for the initial variants that we've seen. However, when it got to Omicron, the effectiveness of protection from having been infected with COVID went all the way down to 56%, which is quite a drop. Looking at those that were severely ill or hospitalized, there was still very good protection at that stage, but certainly not adequate enough to prevent from further episodes, which I think lends us a lens into how different Omicron truly is compared to the other variants. And I think, this is a challenging paper to make generalizable to the Canadian population because vaccine rates here are just so high. I don't know if this is something that we can take to our population, but it may be something that your patients might be asking you questions about what getting infected in itself could do for your protection. And in the face of Omicron and potentially other future variants, what we can see is that protection level likely goes lower and lower. Next slide, please. Another CDC publication that came out February 11th, which I thought was actually quite impressive at looking at vaccine effectiveness, specifically in the face of Omicron. They looked at 2-month intervals and 4-month intervals post third doses. If you haven't heard already through media or through other conversations, the 2-dose efficacy against Omicron does drop quite dramatically. And Zane expressed some of that in some epidemiological curves that were shared at last talk. For example, in this study in the States, where they looked at emergency visits, urgent care visits, and hospitalizations, at the 5-month mark for emergency visits and urgent care visits, the vaccine effectiveness went down to 37%. And hospitalizations at the 5-month mark went down to 54%. So that's fairly low compared to some of the robust numbers we initially got from our 2-dose series when these vaccines first came out, ranging at 98, 99, 100%. This is a very different game. Omicron has changed the game. What we've seen, though, with the stats I'm showing you here on this slide, looking at 2 months post third dose and 4 months post dose, 2 months after that third dose vaccination, we do still see very high efficacy against ED visits and urgent care visits, as well as hospitalizations. It does drop at that 4-month mark to 66% and 78%. But when we look at these numbers, I think it's always important, and I joke about this with some ID colleagues, that if we saw a vaccine efficacy of 60% for influenza, it would be jumping up and down. That's great. That's pretty good. Again, different beast, different game. There's still evidence, though, that getting that third dose is going to protect you further out from hospitalization in the face of Omicron. So there's still a lot of value in having that booster shot provided. Next slide, please. Thank you so much. Bit of a busy slide, but I wanted to display this to you because I think the data that the UK shares is so clear and helpful when they're looking at epidemiological curves and vaccine effectiveness in their population. These 3 slides are showing you the time since vaccine and vaccine effectiveness in their populations. The leftmost column in each of these charts reflects what vaccine effectiveness looks like with either double vaccine, AstraZeneca, Pfizer, or Moderna with 2 doses. It's quite concerning when you see the 2 dots. The darker one, represents the Delta variant, and the lighter circle represents the Omicron variant. You can see that with time, with all 2-dose regimens, the effectiveness of the vaccine drops to less than 20%, and with AstraZeneca nearing almost zero vaccine efficacy at that 25-week mark. If you look over, though, to the middle columns in all 3 charts, you do see that there is some improvement in that vaccine efficacy once a booster dose is added on. And this is again all against all symptoms. The middle column representing the Pfizer vaccine and the last column representing Moderna. What's impressive is how well it works and helps for Delta. What's concerning is the drop that we start to get 2 months out with Omicron. So something to be mindful for. Again, efficacy still landing us in that 50 to 80 range, but not quite what we were getting with Delta with the boosters. This is for all symptomatic illness. Next slide, please. Now, looking at severe illness and hospitalization, this is where I think we truly get the most bang for our buck with that 3rd booster dose. The graph that you'll see that is on the left side shows what happens with the 3rd dose of vaccine. And you can see how with either the Pfizer or Moderna vaccine after a 2-dose AstraZeneca regimen, we do see very high vaccine effectiveness at preventing hospitalization or severe illness, ranging well above that 80 to 90% mark. The next chart that we have here on the slides shows us what happens with the 2-dose Pfizer series and boosters with the Pfizer or Moderna shot. And you can again see that though the confidence intervals are a little bit larger, we're still ranging on average well above 70% at preventing hospitalizations in this population. I apologize, the double shot Moderna Prime with boosters with Pfizer and Moderna have not been uploaded onto my slide deck, but similar to the double shot Pfizer, if anything, maybe a few percentage points less. And so the point of showing you all of this is, yes, we do see vaccine effectiveness drop for all comers, all symptoms, but where the vaccine really matters is for hospitalizations and severe illness. And we're seeing that there are benefits to that 3rd dose. Now, these aren't antibody studies. This is real life. This is what's happening on the ground. And so I think this is so important to understand what that looks like. Next slide, please. Some of us, especially people like me who has a child in this category, was a little bit disappointed to learn that there was a pushback in the FDA ACIP committee meeting that was supposed to happen February 15th this week to review the vaccines being offered to 6 months to the under 5 group. They made a decision to push that back. To wait until there's further data about 3 doses, which based on the slides I just told you, makes a lot of sense. We know that if we're going to lose efficacy, we might as well see what the 3 doses show us before that gets published. Again, we don't have a lot of data on this. Most of the information that we're getting is from press releases from Pfizer and FDA. But I wanted to take this opportunity to just reiterate the messaging from those phase 1 trials that came out for these children, looking at specifically noting that there were no safety concerns in the 6 months to under 5-year group in any of those studies. And there were, at this point, there's over 8,000 children enrolled in this trial in this age demographic. I also thought in the data that they shared, at least, there was very strong signals for the 6 to 24 month group, where the non-inferiority was not quite met was in that 2 to 5 group with that 3 microgram dose. And so the dose is unlikely to change, but I suspect the regimen will be a 3-dose regimen, and that sure, there wasn't a conversation this week, but I do think in the grand scheme of things, this is probably for everyone's benefit. Next slide, please. In the last couple of weeks as well, there have been a couple of publications in regards to protective antibodies in pregnancy. And I think it's important to have this conversation after recognizing sort of the gap in the 6-month to 5-year-old population, because some children may actually fall into this category. This specific JAMA publication, February 7th, looked at infants 6 months post-birth, and they looked at for antibodies in the infants of mothers that were vaccinated versus mothers that were infected. And what was really interesting to see was that 50% of infants had antibodies 6 months out in the mothers that were vaccinated versus 8% in the unvaccinated group. Now, the numbers were small. There weren't too many people in this study. For example, 28 babies were followed in the vaccinated group and 12 in the infected group, but it's still an interesting signal to see. To steal words from another colleague, antibody studies are great, but what we want to know is what does this look like on the ground? What is the actual effectiveness of the vaccines? Next slide, please. And that's where this paper comes in. So this was published February 15th, again, hot off the press, COVID, everything just happens as on a day-to-day basis, where they actually looked at infant hospitalization in women, in babies that were born to parents that were vaccinated versus those that were not. And what was fascinating to see that in the stats for those that were under 6 that got admitted to hospital, 84% were from unvaccinated mothers. And so there's certainly a signal there. There's certainly something that's protecting the vaccinated babies in this population. The table 3 that I've put on this slide for you here shows us some information. And actually there was a subsequent publication to this yesterday, I want to say, which summarized this data as well. Looking at vaccine effectiveness for the babies 6 months out at any time during pregnancy, getting vaccinated with the 2-dose series, which showed vaccine effectiveness at 61%, with a higher vaccine effectiveness after 21 weeks, up to 14 days before delivery. Now, lots of caveats, lots of things to think about when interpreting this data. This was before Delta Omicron. This was not exploring previously infected women. This was not exploring single dose boosters during pregnancy. Putting all of that aside, this is still really interesting to see that not only do we have a recent paper that proves again that we're seeing antibodies in babies, but we're seeing it 6 months out, but it's having some meaningful impact potentially against hospitalizations in this population as well. So I think that's a really good conversation to have with your patients that are contemplating getting vaccinated around pregnancy or during family planning. Next slide, please. Okay, so variants you may be hearing of. I think I saw a question to this effect. The Omicron sublineage BA2 has been, most of the data is really out of the UK right now, and there's buzz about it being 1.5 times more transmissible than the current Omicron variant, which is certainly concerning from an epidemiology standpoint and a transmission standpoint. But ultimately, when we're dealing with our population, where we're seeing a significant number of people that have been vaccinated, we are still seeing a vaccine efficacy ranging us somewhere between that 70% 2 weeks post 3rd dose. There's no reason to suspect that the vaccines shouldn't protect us from it, but there's still a bit to monitor and to be learned. And so for now, I say be mindful and be vigilant and watching out to hear more updates about this, but so far, no major red flags. You may have even heard of this other recombinant Delta and Omicron thing that they're talking about in the media right now, another variant that was commented on in the UK in the report February 11th. There really isn't much detail or information about this so far. I think the bottom line with this slide is to appreciate that we're not out of the world of variants. We will likely see more variants, but in all likelihood, we should still have fairly good vaccine efficacy against them. And I think a bit of a disservice that we've done in the past is sort of present this whack-a-mole model of the immune system, antibody neutralizing antibody. And that's sort of your combination that protects you. But there's so much more of a cellular mediated response that we're starting to learn about that we know about that likely has an impact on your ability to be protected. Next slide, please. This when I put these slides together, this was the newest thing. And so there've been other things that have happened since then, but I have to take a moment to talk about Paxlovid or nirmatrelvir, which is our oral antiviral agent that's been used for non-hospitalized high-risk patients with COVID. We've already adapted this. This is already part of the Ontario Science Guidelines. Many of you may have already seen it on the science table, but this is just the data to support that, which we've, I think, all been curious to see. There was a relative risk reduction, 89.1% of at day 28 from hospitalization or mortality. And so there are certainly some benefits to be seen there in this original paper. Again, a lot more to learn on the ground as we get this used more ubiquitously in our population. So stay tuned. You may, if this comes up with your patients, you may want to discuss the risks of dysphagia and diarrhea on these medications. If anyone has any HIV familiarity with ritonavir, it is notorious for having those side effects as well. Stay tuned though, because we still have a lot to learn, but at least we have some data to work with now. Next slide, please.
Thanks so much.
That's
I think that's the last slide, Richie. Thank you so much. I wonder, Brian, if you could go to slide, yeah, actually just 2 slides back from this. Exactly. So, Richie, I think you've made a really compelling case for why it's so important for us to get boosters. I think there's some comments in the chat about, how people have noticed, unfortunately, that booster uptake has decreased since the vaccine certificate requirement seems to have been signaled to have left. Another physician remarking that one of the reasons some of her patients haven't gotten a booster, though, is because they've gotten COVID and they now have to wait for a little bit. So there's a lot going on there in terms of the third doses, but for sure it's clear that adults need it. There are, though, these questions about teens, and I wanted to get your thoughts on the teens and boosters. So Nasia Jacobs, I think, puts the question well. NACI has recommended boosters for only at risk 12 to 17 years. Ontario today opens up vaccination to all 12 to 17 years. How should we advise our patients, especially seeing that the vaccine, including boosters, seems much less effective against Omicron? Well, so she said that. I think you have illustrated actually that they're still very effective against Omicron and much more effective than the second dose. But I wonder if you could answer that question about how we should advise patients.
So certainly, I think when we're triaging this conversation, it should happen for the immunocompromised and those that are at higher risk of infection first. I think that's a very important conversation to be had. The US has actually already authorized this population getting boosted for several weeks now. There haven't been any signals of concern. I do think the pros and cons to getting vaccinated still do remain high in this population. Again, as an adult infectious disease doctor, I'll just give you my 2 cents. I do think that there's a lot of factors that go into the teenage experience and the return to school and exposures that come along with that might provide them with benefit to being vaccinated, even if it means less time away from their education and their activities. There's a lot of value there. And as family doctors, this is certainly a multidisciplinary conversation. It's not just about COVID. There's so many ripple effects from getting sick from it that there are impacts for. And at a population level, certainly the more people we have vaccinated, the wall of protection that we create in our community. I think that we've talked about this previously, Tara, but there's some reservations from parents and kids in this population because of myocarditis concerns from previous, from a lot of the documented cases that have been investigated so far. In the studies that were preliminary put out from Israel looking at kids 12 to 15 who got boosted, there were no children in those studies that got myocarditis. Granted, when we get into the hundreds of thousands and millions of cases, there certainly could be some. There's estimates that myocarditis risk may range somewhere between that first and second dose in terms of rate. But right now, certainly weighing the pros and cons, especially with the data I've just shared with you, I do think those boosters are really important for our kids.
Thanks, Richie. That's helpful. So I think, I think what's unfortunate is right now we do have sort of almost like conflicting guidance, or it seems, NACI's come out in one way or hasn't actually come out very clearly and said it's recommended for all, whereas in Ontario now it's available for all. But I think it's reassuring to say that in other jurisdictions it has also been recommended for all and what the evidence is. And there's the individual level considerations and also the community level. And then there's the issue around interval as well. So just a couple of follow-up questions. One is from Jordana Sachs. She asks, is there science behind the 6-month booster for teens? So I think she says the CDC recommends 5 months. So is there science behind the 6-month interval?
So the CDC, I believe the rationale for pulling it earlier to that 5-month versus the 6-month was in the face of Omicron. as we've seen with the primary vaccine series, the delaying of that second dose is certainly in our interest to try to boost the immune system long-term as best as possible. I'm not sure where they're going to land eventually from NACI's perspective, and I personally don't know the data off the top of my head, but I have seen that the CDC has just very recently pulled that down, and so I wouldn't be surprised if our regimen goes down to 5 months as well, especially in the face of Omicron, but I don't know the date on that personally.
And then Alan Grill asks, given individual benefit against severe COVID disease is lower in healthy 12 to 17-year-olds, given their baseline risk is low, what % of uptake of boosters for healthy 12 to 17-year-olds is needed to have an impact on transmission to protect more vulnerable patients in our communities?
Excellent question, Dr. Grill. I don't know what that magic number is, but you're right in the sense that there is certainly some level of protection there. And I think that we don't really have the clear summary from NACI yet to explain, because they haven't really given the green light yet, to explain what they're thinking behind that process. The Europeans have released a fairly detailed document for this group, and they're sort of more aligned with where NACI stood on January 28th with their recommendations for 12 to 18. And so I do think that 12 to 17. So I do think that the details from Ontario, I haven't seen too much of it, but I suspect it's modeled after what's happening in the States, where there's still benefit. And ultimately, again, as a non-pediatrician, I hear this all the time, kids shouldn't be in hospital. They should not be sick in hospital. And so our expectations for this mild illness conversation really need to go away when we're talking about this population, because they shouldn't be sick, dying in hospitals, any of them. And so I think that that's definitely a loaded conversation that we'll have to explore further as we get a little bit more information.
And so just to clarify, Richie, are there actually studies in the teen population looking at the third dose?
Yes. So I mentioned there was an Israeli study that they looked at this specifically, looking at the third dose, and there was strong vaccine efficacy when they investigated these 6,000 kids in Israel. It's not peer reviewed yet, still waiting on the full data. And there's also a non-reviewed paper coming out of Singapore, which showed similar trends.
Great. I think Mark Dagger just noted that Health Canada approved the booster for 18 plus, and he wonders if that will be a worry for some patients. I don't know if you have any thoughts on that.
The booster for 18 plus, just in the third dose. So I guess another thing,
Health Canada approval, which it's a good point that Mark makes. I will say that also, will also say that I know that Kim Moran and Liz and others are also speaking with the Ontario Immunization Advisory Committee, and hopefully we can provide some more information to family doctors based on those discussions. I don't know, Liz, if you wanted to speak to that, but I think it is a tricky area because of the differing, I think, provincial versus national approach.
Yeah, I don't know that I can speak to an answer, but I think you're right that we are, hearing from family docs about these, just the confusion. That's been an ongoing thread through the whole pandemic, and we understand that. So we are bringing that forward. So stay tuned, and we'll continue through our regular channels to be in touch with you, like our messaging, and then our next COP if we get anything more to share.
Exactly. I'm going to go 2 slides forward, Brian, to Novavax, because that's the other thing that happened hot off the press, even after Ruchi put together her slides. So Ruchi, I wonder if you wanted to just speak to this briefly, and then we'll take one more question to you and then go to Liz.
So yes, you may have heard on the news yesterday the approval of Novavax for 18 plus. I don't have logistics answers for how this is actually going to be rolled out, but I thought I'd take the opportunity just to inform you that there was good data looking at over 90% vaccine efficacy in this population. And although this paper is actually out from December, where they looked at this data initially, unfortunately, these efficacies don't, although it was 90 plus efficacy for symptomatic illness, it was 100% for hospitalization, severe illness in this population. So good data. This is pre-Delta, this is pre-Omicron, and this is still something that we don't have a lot of information on. If you do look at the NACI suggestions, they still suggest an mRNA series as your primary series. we don't have data on what a booster regimen would look like while using Novavax for that. So stay tuned if there's more to learn there. Basically, my sense is that they wanted an option available that was not an mRNA vaccine for anyone that had concerns for mRNA vaccines themselves and wanted a protein unit derived type of vaccine similar to hepatitis B, for example. Instead of that, going through the monograph, there are certain product components that might be a bit different if there was an allergy concern related to the mRNA vaccines. And so certainly something that I think the COVID-19 allergy e-consult service may be a benefit to if someone is sort of teasing out allergies in patients to components of the mRNA vaccine versus Novavax, this may be a good option. Again, I hate to be that person, but stay tuned. I don't think we have all the puzzle pieces on this yet. What's been reported in NACI is that there was a lab-based antibody response when challenged with Omicron. There was some detected neutralizing activity. And so the hope is that it will still work, but there's still so much to learn about what this is going to look like on the ground.
Thanks, Richie. So I think people want to know how to access Novavax for their patients. And I think we don't have the answer to that right now. But for the other non-mRNA vaccines, for the most part, you can you order them through your local public health unit, specifically for specific patients. And I think the process is fairly straightforward. And so presumably that will be the same way in which we do it for this, but we will certainly keep this group up to date once we have more information. And I know the OCFP team is going to be working on that as well. I think the last question I want to pose to you, Richie, and then I'm going to turn it over to Liz. Reminder, everyone, we're going to 9:15 today. And so, you talked a lot, Richie, about the waning of immunity of 2 doses and then how it, increases back for 3 doses. And then one of the studies you quoted, it looked like even for 3 doses, if it goes over time, there's some waning. And so naturally, there are some questions now about, will we need a 4th dose? Who will need a 4th dose? When will we need a 4th dose? And I don't know if you have any insights on that.
My crystal ball tells me that we could very well need more boosters. And I know that there's a lot of research happening on the background for more Omicron specific vaccines. The truth is, I think we need to sort of mentally accept that there will probably be more variants and more waves, and that what we've seen statistically, and frankly, being on service for 2 weeks for ID on the ground, is that in our unvaccinated and immunocompromised individuals, this is a completely different game. In our vaccinated individuals, if they're in hospital, they do better and they get out quickly. They're not in the ICU. They're just not representative of that population. So to answer your question, I don't know. What makes sense for seasonal coronaviruses is that they really do ramp up in that fall to winter timeframe. And so if we needed to get our protection again by the fall, that would be something that would make a lot of sense to me. But I'm not really sure what's actually going to happen. As someone that's probably now 3 months out from my 3rd booster, that is still seeing COVID patients in hospital, this is personally very important to me as well. And so I think that it's a lot, as it is to a lot of you, I'm sure, as well at this point. So again, stay tuned. I say the only thing predictable about COVID is that it's unpredictable. So just be mindful that there could be other variables that come at us in the coming months. But what is very reassuring is that we're still seeing quite a bit of effectiveness against hospitalization and severe illness in those that have been vaccinated so far.
Thanks, Richie. So we'll certainly keep this question in mind for future sessions to try and see, keep you guys up to date with the latest on new variants, on new vaccines against potential variants, and also whether 4th doses are going to be needed and offered to folks. And I know many of you are anxious about that, being many months out now from your 3rd dose yourself. But without further ado, I'm going to turn it over to you, Liz, to help us. I think we've been answering lots of questions, and as usual, flood of information and change. And just as we think we're coming out of it, there seems to be maybe new stressors. So yeah, how can we better manage this for ourselves, Liz, and take care of ourselves with everything going on?
I think, exactly where I was pivoting to, Tara, that, it just is a continual marathon. And I think what we're seeing is that there likely will continue to be reprieves through these waves that we have, but we're looking at a continued journey through COVID, and we're all looking down the tunnel at as the waves kind of peel back the backlog that's there that we have to address. And so I just wanted to spend a bit of time looking at kind of where are we in this journey now? How are we feeling? How do we help ourselves? How do we help our staff? And these are questions that we're getting from you. I like to turn to this graph, which was really how we used to understand the pandemics of the past. There's the timeline on the bottom of how long pandemics normally lasted. You can see it says up to a year, and then the up and kind of how we're feeling. You can see that there is a period, acutely where we rally, where we come together, and then as the stress continues and we're in a chronic stress cycle, I think we know what it feels like now. It's a long journey and a tremendous amount of fatigue. So that's what we're seeing the most, is just that we are all really, really bone tired. I've been in practice a long time, and I've never felt so tired as I have felt through this last wave. But I think there is reason to feel hopeful about where we are and where we might be going and our capacity to continue. And that's what I want to look at now as we head into this period post-Omicron, I think, which is a period of some sort of a mini period of recovery and also some meaning making and adaptation. And if you just go to the next slide, it can feel a lot like that top piece that, what is happening here? Is this just going around and around, or maybe going backwards? And, there's no question we've all had losses and we're grieving, and we've had challenges for ourselves, for our children. At the same time, I think it's really important to know that we are moving forward. We need to feel the comfort of and the inspiration from the positive learning that we have gained through this. And I just want to reflect that back to everybody on the call, the new ways of working that we didn't have 2 years ago. We kept our lights on, we've shepherded our patients through this time, and found new community solutions. So, we are moving forward despite the fact that it feels like we're in the same place, very same place again. That is not the case. And on the next slide, just some ways to sort of think about what do we do now. And I love this photo montage. These are all family docs from Ontario. So you may actually see yourself in some of those, reflected in some of those, literally or figuratively. I hope you see yourself. So the first thing for me, just back to the fatigue, is really taking the time to recover, to give yourself that permission to recover and exhale. And I've embraced, Socrates has a line that is, to be is to do. So just being is a really important part of what we need to do now in terms of recovering, whatever that means for you. And I think that's what we know, is that all of you know what you need to be able to recover. And so to give yourself the permission to take the time to do that. Reconnecting with the work that we do is critical. We have had, as family doctors, the most critical role in this pandemic of the long trusted relationships with our patients, guiding them through this. They would not make it through without us. And, to reflect back for each of us on the, thousands of patients that you have assisted over this time, and the tremendous value of that work. I'll give you a little story. I'm in Ottawa, and Ruchi and I are both in Ottawa, but I found myself in a very long lineup of cars for hours, actually, with my daughter, and lots of people who were part of the protest who were in this long lineup of cars. And I was getting frustrated, and normally I keep my cool, but I turned at one point to somebody beside me in one of the cars, and I said to my daughter, I'm going to give this person the thumbs down. And this is just between us on this call, I guess now, but so I gave the thumbs down, and then I sat there for a few seconds, and I said to my daughter, I said, you know what, I feel worse. And she said, well, yeah, I'm not surprised. And she's like, what would make you feel better? And I sat for another second and, this long line of cars and thought about it. And I said, well, actually, what makes me feel better are the conversations that I've had as a family doctor over the course of this time in pushing and supporting and informing them about the need for all the public health measures, including vaccination. So just, I think that concept around the kindness to ourselves and digging into the purpose of our work and how critical that is to keep us moving forward. And the last thing I'll say is just on the relationships and really the need for us to connect with each other. I think there's a tendency in the hallways when we see each other to feel so tired that, we can say like, hey, how's it going? But we need to try to do more than that. It's good for us and it's good for our staff. So really reconnecting, and I continue to find, these sessions for me on Friday, a wonderful way to reconnect with all of you, but whatever that is, finding those opportunities. And I think those are, again, back to that piece about making meaning of the place that we're in. We know that to help us get through this, and actually as an antidote to burnout, when we have an opportunity as physicians to talk to each other about what we have been through, what it meant, and what we're taking from it, in that spiral journey, that really can be a powerful protection against burnout. And the last thing I'll say on this slide is really just for our own staff to turn to them and what can we do for them. I mean, some of these concepts still apply, of course, or do apply to them. And I think really paying attention to your staff, acknowledging the stress for them, talking openly about what it's been like for you, and normalizing, you could be anywhere on that spectrum. Probably all of us have felt that, from just mild stress to really something more in that red zone, so normalizing all of that for your staff, reminding them of the value that they've had in the care that has been provided to the patients. I think when they're 1 or 2 steps away from what we get, the face-to-face, it's really critical that that we remind them of that. And then I think taking stock in the learning. So what has happened in our clinic? What have we learned? What have we done? What's worked well? And bringing them along in that journey, again, on the meaning making and the kind of moving forward is really critical. If you go to the next slide, I thought I'd share a few other pieces. I think one of the things we recognize everywhere now, and definitely we feel deeply at the OCFP, is that if we want to have joy in our work, I mean, a part of this is around our own individual selves, for sure, but so much of this is about what is happening in the workplace in terms of culture and efficiency of our work. And we are absolutely committed to addressing this as an organization. It's one of our 4 strategic priorities. So I've just put the 4 up there, and the one around joy in work and making work easier for all of us as family doctors is in the bottom right. So we will be relentless in this effort and in connecting those dots in the work that we do to support you and advocate for you. And the next slide is a list of physician wellness resources. I would encourage you to keep these on hand. As I said, we can feel all different things in that spectrum. And if you know you're getting into that red zone, or somebody that you work with is, there are a lot of supports out there. They are anonymous. Nobody is going to take your license away if you're not feeling well or you reach out for help. You can call the OMA PHP 100% anonymously. So and that's all available on our website, and Tara and I have shared this on previous calls. And if you just go to the next one, a couple of, I'd say, fun things to take a look at as we try to recharge. So we had a lot of sessions at the OCFP Summit that dealt with different aspects around burnout and joy. You can still access those until July 31st. We have a great community of practice called Practicing Well, which really focuses on these issues of caring for our patients who may have mental health and substance use and chronic pain, but also caring for ourselves. And we have our next session actually is on undifferentiated distress, which is a really good timely session on the 23rd. And then CFPC Learn also has physician wellness small group learning program. So this is a small, like 6 family docs getting together, and that is main pro accredited as well. So lots out there for you to connect with each other and get credits at the same time. So, and I think that may be the last slide that I have.
Thank you, Liz.
Sarah,
I mean,
you're welcome.
I think from the comments that your presentation really has hit a nerve and resonated with so many on the call today. We're joined together at this point with about 630 other family doctors. I know at one point it was over 800. And, you know, people are saying thank you to you personally. I think Heidi Chestnut said something very nice there. Tears of gratitude and connection. Thank you, Liz. I will say myself, it's been a low time for myself, even over the last couple of months, and in particular the last couple of weeks. And I've had to, you know, deliberately take a day off for a personal day to just make sure that I had time to reset and do something non-COVID, to reach out to friends who helped to sustain me. And at this time, I actually also want to just give a shout out to my own clinical colleagues who have helped me to stay centered and who've always been supportive. So I think that really resonates for me, Liz, your advice around relationships and reconnection and learning, which I think has been really helpful for so many of us. So you'll see a lot of comments there about that. So I'm just going to wrap up with a few additional, I guess, new points and reminders and things that you might want to know about. Next slide. Next slide after that. I wanted to just highlight for folks that there was this new science table report on rapid antigen tests. We know these are going to be more available to patients, and they do formally recommend now that people do both a throat and nasal swab and not just a nasal only. And there is actually a video there that can be helpful for patients on how to do that. And the reason why is the throat and nasal is more sensitive. But even with that, it's important to note that the throat and nasal swab still has some weakness around sensitivity. And so if we get a positive rat, that's great. We know we have COVID. If it's a negative rat, we can't be reassured. So just to convey that to your patients is important. Next slide. And we're going to skip through a couple, which we did. Next slide. And next slide. And so I just wanted to highlight here, I know some people have been asking about access to sotrovimab and Paxlovid, and Ashley put together this slide, which will be in our deck, around how to access some of that for long-term care patients in the Greater Toronto area. Hopefully there's services like this outside of Toronto as well, but for those in the Greater Toronto area, there's a 1-800 number to call to access it using the LTC Plus pathway. Next slide. In those in the Greater Toronto area, there is also this, you would have gotten this memo, I think, from Ontario Health that talks about how your patients can also access a COVID Care at Home program. If you're not running one yourself, they can access one by calling this phone number. So again, it'll be in our slide deck and you could take a look there. Next slide. I wanted to highlight that our Confused About COVID resources are now up in several different languages: French, Spanish, Farsi, Korean, traditional and simplified Chinese. And we do have one handout on what happens after I get COVID that has at least one resource and some discussion about long COVID. We probably can enhance those. And there are a couple of new resources around medications and what type of mask. So check those out. Next slide. I wanted to mention to folks around the global blood tube shortage. This is a great new release from Choosing Wisely Canada that just reminds us about choosing wisely when it comes to test ordering. I don't have a slide on this one. I forgot to put a slide together, but I wanted to also let people know, of course, this is Black History Month, and I've just posted in the chat a link to a terrific video that colleagues of ours put together, led by Anya Norum, around how to approach vaccine hesitancy among the Black population. We know most of our Black patients are vaccinated, but there is still a disproportionate number of the unvaccinated who are Black Canadians, and there are, some really important historical reasons why that might be. We're mistressed. And I think this video from Anya and her team really helped, that the OMA worked on with them, really helps to put that all into perspective and provide some practical advice about what to do. Next slide. A reminder too that one way of showing gratitude and being positive is to nominate your colleague for an award and so the OCFP award deadline is March 13th. So please do think about that. Next slide. So thank you to everyone who continues to log in. I've heard from you that this is an important community now for all of you, where you can get updates, but also feel connected and get validation about common concerns and dilemmas, and just hear what's happening with others, whether that be in the chat or through the panel or through the Q&A. So thank you for continuing to join and make this special. We're going to have our next session in 2 weeks. Please do fill out our evaluation. We'll have a few extra questions in the eval because as we're coming out of Omicron, we're reassessing sort of, what should these community of practice sessions continue to look like? And we'd really like your input into that. So please do fill out that evaluation. And lastly, thank you to everyone. This is the National Week of Kindness. So just a reminder to, show that kindness. I know you do all the time to your patients and probably to your colleagues, but sometimes we don't always show that kindness to ourselves. We have a great long weekend coming up. I hope you all get some time off, and please take care of yourselves, and thank you for everything that you do.